I'm Bruce Cohen, and I'm president of the Friends of Brookline Public Health, and I welcome you all this evening. This is one of the keystone events for Friends of Public Health, but this is a local organization that supports public health enterprises and activities here in our incredible town. We do several things. One, we recognize public health achievement, and this year's Public Health Leadership Award went to Professor Ted Colton, a distinguished BU professor of epidemiology and dean, and I saw Ted earlier. There's Ted right there. We also give community awards, and this year's Carlin Community Health Award was given to Chobi Hoy. Many of you know Chobi. She's an incredible activist and a really strong supporter of improving the quality of life here in Brookline. So Chobi won our Public Health Community Award this year. I've almost filled up my time now. The Friends also do a couple other things. We try to promote, through modest contributions, supporting local community health initiatives. And this year we gave money to support Brookline's Climate Action Week. We gave money to support the Environmental Health Division. They have an online quiz. Go on the web and take the quiz. You can learn a lot about public health. We continue to help support Brookline's Sister City Health Committee, which does phenomenal work in Quesahuaque, Nicaragua. And we're considering trying to provide little seed community mini grants for folks in the community who want to start or continue some of their local activities. So I urge you to join. There's information about how to join in the brochure. And before I turn it over to my colleague Jacques to introduce the governor, there's one other incredible activity that we do, and that's support our local health department headed by Dr. Alan Balsam, the best health department in the Commonwealth. Thank you all for coming this evening on such a hot and muggy night. We really appreciate you coming, and we've got a great program this evening, and I'll turn it over to Jacques.
Thank you. Good evening, and welcome again. For 18 years, we've been gathering here in various places around town to have this public health policy forum. For 18 years, we've done our best to put together great panels to discuss big topics in public health. Those are constants. Other constants, of course, is, as Bruce mentioned, that the Brookline Health Department is run like a clock by our able leader, Alan Balsam, and his staff. Bruce Cohen has capably and ably handled the Friends and doing so much with so little, and has done that for many, many years, I'm proud to say. And I've had this sort of, regular role over the past 18 years. I think I missed 1 year where it is my role to introduce our moderator. And I think my role is the one that's quickly becoming obsolete because he already knows everybody in the room. But that being said, it's a real pleasure to introduce Brookline's own, our governor, Mike Dukakis, the Honorable Michael Dukakis.
Thanks, Jacques, and thank you all very much. I may have told this story before, but every once in a while people say, this man needs no introduction. That is not true. People under the age of 30 have no idea who I am. And that number goes up 1 every year. I was on the platform at the Ruggles Station, which, as you know, is right next door to Northeastern, where I've been teaching for the last 22 years. And I was going downtown, and there was this young man who came up to me, he looked me up and down, and he said, hey! And he said, ain't you the mayor? And I said, well, you're close. You're close. I don't know where Alan, Jacques, and Bruce, and our pals here get these panels, but they're always terrific. And one of them, who we had last year, is going to run for governor. So if you're interested in announcing your candidacy, ladies, let us know. But we have another terrific panel. And they're all women. I mean, However, I will take a certain amount of credit for two. Gene, did you ever work for me? Did you ever work for me? Oh. Terrible, terrible hole in your intellectual development here. Anyway, but two of them worked for me, and I'm very proud of them. They've gone on to do great things, and what I'm going to do is just introduce them all briefly now so that they then can get up and do their thing. 10 minutes, ladies, no more, okay? Because the best part of this, is, you can imagine, is what is described as the freewheeling Q&A. And it is. And Alan, you're the timekeeper. At 9 minutes, please put your hand up, so our friends here can begin to wrap up their presentations. But we'll have a good, lively discussion, and I hope and expect all of you will be deeply involved, and I'll do my best to field the questions. But here they are. Jean Yang, who's just joined us, is bright as hell. She's a graduate of the Harvard Business School, among other things. She was the chief financial officer of the Connector, which is the prototype for all of these exchanges that are now being created all over the country. It was the Massachusetts Connector, as we call it, that was the model for that. And they're all flocking to her door to find out how we do it. She also employs a number of my former graduate students who are doing great work. You probably don't even know who they are. But Caitlin Kenny and Dan Apicella, and these folks, I had some kind of a hand in training them. And they're wonderful, let me tell you, folks. We're producing fabulous young people in this country, and they're doing public service. Now, what about these other two? Well, they work for me, too. One started when she was quite young. In fact, she showed me a picture of the two of us, and subsequently became one of the best commissioners of mental health we've ever had in this state, and was really the person that drove the mental health parity debate to a successful conclusion, folks, so that we no longer make this distinction between mental health and other kinds of health when it comes to providing care and insuring people. And she's now an academic at the Boston College School of Social Work, but ran the Massachusetts Society for Prevention of Cruelty to Children for 9 years. And Nancy is, I think, one of the great people in public health in this state, and keeps reminding us that markets really don't work in health care. You got to regulate the thing, but not over-regulate it. And maybe we can talk a little bit about administrative simplification in the course of our discussion tonight, because we're spending billions and billions of dollars, folks, these days, doing nothing but servicing this cockamamie health insurance system of ours. 25 cents of every premium dollar in the United States goes for administrative overhead. Can you believe that? Talk to your doctor. Tell them what it's like to wrestle with. Talk to the folks at the New England Medical Center, where they have 500 salaried employees doing nothing but collecting from insurance companies. Can you believe this? 500 salaried employees at a medium-sized hospital, a good one, doing nothing but arguing with insurance companies all day long. It's really nuts. So here they are, and we're going to start with Nancy. Yes? Is that the agreement? Then we're going to Jean. Then we're going to Mary Lou, and then we're going to you. And we're going to have a good, lively evening, as we always do. So, without further ado, Nancy Turnbull, the Associate Dean for Educational Programs at the Harvard School of Public Health. You want this here? That'd be better.
Yeah, that's great. I'm tempted to announce my candidacy for governor just for fun, but having served under the best governor ever, I would not be up. Oh, sorry. I'll actually hold it. So anyway, so I'm very pleased to be here with you tonight. I think this is maybe my 4th or 5th time at this event. It's always a wonderful event, and I'm always delighted to be with Governor Dukakis, but particularly pleased to be here with Jean and Mary Lou, who are two people that I really admire and enjoy working with. And as you'll discover if you've never heard Mary Lou in particular talk, that you're in for some, she's very, okay. Mary Lou is very irreverent, which I always enjoy, and I'm sure I'll get some pithy things that I can plagiarize and take credit for. So So my role, I'm going to give you a little bit of an overview of what's going on with health reform at the federal level. And then Jean's going to talk about what's happening here in Massachusetts, and then Mary Lou's going to talk about mental health and I'm sure a number of other things too. And I in particular want to give you some context on the national level because there's been so many lies and untruths that are being told about reform at the federal level that I want to kind of create the context for the conversation. So this is a very exciting but a very challenging time at the federal level as after 3 years of the law being passed, the major provisions of it are about to be implemented. And the law survived 2 near-death experiences. One was the Supreme Court ruling last summer, and the second was the election last November, but has emerged still largely intact. I will say at the very outset that while this law is far from ideal, and it's certainly, if I ask students in my classes, design a great way to expand coverage, you know, I might give it a B. But it is, I'm absolutely certain it was the best law that could have gotten through Congress in 2010. Despite its imperfections, my view is a tremendous step forward for the country, and in particular, I view it as one of the major pieces of legislation that is going to promote social justice and health equity. And as all of you know, we're the only major industrialized country that doesn't guarantee health coverage for all of our citizens. We're the only country that lets people get sick and go bankrupt as a result of this. So I think this law is the beginning of a path to a better place, a place to improvements in the healthcare system, a path to real financial security for most people. And I think there's so much in this law that's going to lead to better quality of care for all of us. So I think it's well worthy of support. On the insurance side, which is those are the pieces that are about to go into effect. If it can be fully implemented, and implementation of some of the major portions of the law is being done at the discretion of states. So we're going to have very uneven implementation, and I want to talk about that. It's going to give, if it can be implemented fully, 32 million additional people in the country health insurance. The thing that I think is the most exciting about the law, but the most in peril at the moment, is that it will finally offer Medicaid coverage to every person in the country who is poor. Now, most people think our Medicaid program already does this, but in fact, it does not. So Medicaid is not available to every poor person in the country. It's only available to certain poor people. And so this will finally realize the promise of the Medicaid program, if states will implement it, that it will become the essential health insurance program for all poor Americans. And that will be the biggest change in the Medicaid program since it passed in 1965. Beyond Medicaid, it gives subsidies to try to make coverage more affordable to another 16 to 18 million people. And so that will be tremendous. And disproportionately, the people who will be helped by this law are Black and Latino, because those are population groups in this country that very shamefully have rates of uninsurance that are 2 to 3 times the rates for white people. So this is a major step forward for beginning to redress at least one aspect of racial and ethnic disparities in this country. It's going to get rid of most of the worst practices that go on in the health insurance market, ones that I'm pleased to say we've not permitted in Massachusetts since Governor Dukakis was in office. But it's amazing if you go to other states to see the things that they still permit. So women can be charged higher rates than men. You can be denied insurance if you have health problems. So these are going to go away. It's going to transform the private health insurance market in most states. And there's lots in it, not just for people expanding coverage. So it's going to close the Medicaid donut hole in the Medicare drug benefit. Over the next 6 years, it's going to significantly eliminate that gap in coverage in the middle. We've had many preventive services already added to the Medicare program, including annual wellness visits with no coverage. It's increasing Medicare payments for primary care doctors. And beyond these health insurance provisions, there are billions of dollars in this law to make major investments in public health, in prevention, in community health centers, in school-based health centers, and to undertake initiatives which are already underway to try to improve quality of care and safety of care. So I think this is an extraordinary law, and it's well worthy of active and enthusiastic support. Alas, that's not how everyone in the country feels about it. And it's, unless you've been in a cave somewhere, you know that it's a deeply partisan issue, and the picture's very different. So I think what we're going to see is 3 different groups of states. So we're going to see a group of states that include Massachusetts that are going full steam ahead to enthusiastically implement the law. And those states track somewhat. They're the states on the West Coast. They're the states on the East Coast. So California, Oregon, Washington, Minnesota, Illinois. Then there are going to be another group of states that are going to be dragged, but they're going to go along. And then there are, unfortunately, it's almost the majority of states that are saying, hell no, we will not go. And this is particularly true. The measure of this is whether states are choosing to expand their Medicaid programs. So the devastating part of the Supreme Court decision last summer was it leaves it to the discretion of individual states about whether they will take advantage of the opportunity to expand Medicaid. And there are 17 or so states, about 20 states are going to expand Medicaid, 3 states are leaning towards expanding it, and then we have 16 states that are not going to expand Medicaid. Unfortunately, the recalcitrant states include some of the states with the largest number of people who are uninsured. And the biggest one I would point to is Texas. So Texas has more uninsured people than we have people in Massachusetts. There are about 8 million people who are uninsured in Texas. It's almost 1 out of every 3 people under the age of 65. Pennsylvania is another state with a lot of uninsured people, North Carolina. So there are 2 reasons why they're not doing it. One is ideological. A second is worries about costs. So as probably many of you know, Medicaid is a partnership between the federal and the state government, and that includes the financing of it, so it's jointly funded. Each state pays some percentage of the cost of the Medicaid program, and that varies by the income of the state inversely. So Massachusetts gets about 50 cents on the dollar back from the federal government for every dollar that it spends on Medicaid. Poorer states, so Mississippi gets about 75 cents back for every dollar that it spends. Now, these expansions in federal reform are almost funded entirely by the federal government. So in the first few years, it's almost 100%, and then it's going to continue to be 90% for the foreseeable future. So that's a much more generous match. So there are incentives in the law to make states want to expand coverage. So some states are complaining even about the small amount that they'll have to pay, but the bigger worry is that it's something that, and I don't like this phrase, but this is what it's referred to as, people call it the woodwork effect. So the concern of many states is that if they expand Medicaid and start doing outreach, make people aware of the program, that some of the millions of people who today, with no expansion, are eligible for the Medicaid program will finally sign up. So, and states vary tremendously in how well they do outreach and enrollment to people who are eligible for Medicaid. So Massachusetts were one of the 2 best states. Somewhere between 85 and 90% of people who are eligible for the Medicaid program in Massachusetts actually get enrolled. The worst state is Oklahoma, where 40% of people who are eligible get enrolled. And the average in the country is about 60%. So the concern of many states is that all of these, millions and millions of people who are eligible and for whom the states have to pay a higher share of the match will join the Medicaid program. And if lots of people sign up who've always been eligible for Medicaid, but we just haven't reached them, that's going to be expensive for states. So particularly in a difficult economy, in a difficult financial time, this growth really worries people. So So beyond Medicaid, as I said, there's subsidies for people whose income is higher than poverty, up to about 4 times the poverty level. So the very cruel situation that's going to happen in many states is that if you're a state that doesn't expand Medicaid, people whose income is above poverty will be eligible for subsidies. People whose income is below poverty will get nothing. So only in America would we expand coverage and have the only group of people who don't get coverage be the poor. And this, alas, is what's going to happen in states like North Carolina and Texas. And alas, if you look at the states that are not expanding Medicaid, they're largely poor southern states where the need for Medicaid is extreme. So, my hope is that we can have many states join Massachusetts in having success expanding coverage. And that success will say that we're not just some weirdos in Massachusetts who've done it, but it's actually possible to do it in other states. California is critical. 1 out of every 7 people or so who's uninsured lives in California. There are about 7 million uninsured people there. So if we can have enough states show success, I'm hoping we can shame the other states to come along. There's lots of work to do. So Jean is one example of the work that's going on here, that's going on in other states. Lots of work to implement the law, get the word out, find people, get them enrolled. Alas, we have many people in Congress and in state legislators who are doing everything they can to thwart implementation of the law, and then they're complaining loudly that implementation is going poorly. So we have to get through that. It's going to be rocky. It's going to be messy. It's going to be controversial, but I'm convinced with efforts of people like Jean and her counterparts in other states in the state Medicaid program that we're going to get through this. And we're going to have to tune out a lot of what we're going to hear on the airwaves by people who hate the law. But I think we can have success. We can begin to move down this road. We know that giving people health insurance expands their access to care, gives them financial security. We have growing evidence in Massachusetts that it improves health outcomes. And I really hope that if enough states can be successful, that we'll get the other states to join us. So I think that's my 10 minutes. So.
Hello, my name is Jean Yang. This is my first time here, which is why I spent about 20 minutes trying to find a place to park, and until I came downstairs, they actually told us that we had reserved parking, which is really really excellent. So thank you for having me. It's always great to sort of be a speaker after someone that paints the landscape for the national reform, because it's really an exciting feeling to know that the vision for the nation is actually reality around you. So if you look around what is happening in Massachusetts, we do have 97% of the people already insured. We have a place where people can find not only insurance, but also affordable insurance, because we already put in place a system where, based on people's income, there is appropriate subsidy that is available. And we also have for the most part, pretty well-regulated insurance market. So insurance companies, for example, cannot deny people's insurance because they have pre-existing condition. And insurance rates are developed in pretty, rigorous algorithm. So, to ensure that there is enough fairness going on. So we have come a long way pushing our health insurance market to what we think is in the right direction. And if you look at my micro world, the Massachusetts Health Connector, you will see a lot of sort of, this vision and this concept happening in real action, which frankly is what got me to this role 3 years ago to the Health Connector. Personally, I think this is the most exciting job that anyone would ever find in a lifetime. I'm really privileged to serve in this organization. we have 250,000 people obtaining health coverage through us, some of them with subsidies, some of them do not have access subsidy because their income is greater than a certain level. Many of these 250,000 people were uninsured prior to the reform took place 7 years ago. And today they have access to not only coverage but good coverage, and that is something that really excites me every day. So if you look, if you have a chance, I welcome you to come to our website. It's www.mahealthconnector.org. And we are essentially a marketplace for health insurance. If you come in here, you can see health insurance plans that anyone can have access to. And not only do you have health insurance plans, but it's actually a very simplified shopping experience. Health insurance is very complicated. But what we try to do is make it very easy for our consumers and our small businesses who access insurance coverage through us. And one of the things that we do, for example, all the health insurance plans that we sell, they are the same. We standardize them so that an average consumer can come in and say, this one looks like a better deal. This one is more expensive. Guess what? I don't see why it should be more expensive because the price, the product design is the same. So, this is the type of concepts that we try to really promote to simplify how health insurance as a product, as a very important sort of consumption for people can be something that is actually understood and well managed by an average consumer. So I would say that in our 7 years of experience, we learned a lot, and we made progress in various directions. Our work is not done, but we're very proud of what we have achieved. For example, in one of our programs, the larger one, Commonwealth Care, some of you may have heard that. It's a subsidized insurance program. We cover about 200,000 people. If you look at the cost increase over the 7-year lifetime, it's actually just under 1%. So compare with what has happened in the rest of the market. How many times have we heard double-digit healthcare increase, which is increasingly unsustainable? But in our world, we have achieved something that looks very different. Some years are a little bit higher. Some years, actually, more recently, for example, pretty significant decrease, which we're very, very proud of. We were able to do this with a lot of support from our sort of advisors and stakeholders, but certainly our board. Nancy is one of our board members, a very important thought partner in everything that we do here at the Connector. So the governor made, I think, very interesting points about some of the important work that Nancy did, which is healthcare is not a market. You need to regulate it. At the same time, you don't want to over-regulate. You want to strike that right balance. I don't think any of us have quite figured out that sweet spot yet, but I would say that with our Commonwealth Care program, we're making some pretty good progress getting to that point because it's a private insurance program. It's very, very tightly controlled, and there is still competition. So we have a lot more to figure out, but we are very encouraged by some of the work that we have done and then some of the outcome that we have seen. Fast forward to just a couple of years ago, as we all have talked about in a past hour or so, the national law passed, and much of it is modeled after Massachusetts. And so we see some of the concepts that we have tested being further expanded nationwide, that everyone needs to have health insurance, and everyone needs to be provided affordable health insurance. There needs to be a place where such affordable health insurance is provided and delivered in a very easy to access fashion, which is the exchange. This is why many other states, not every one of them, is working very hard to set up exchanges, just like the Health Connector in Massachusetts. And the insurance market is being reformed as well, because as I have spoke about a little while ago, the insurance market is very complicated, and some of that complexity, unfortunately, is a driver of the cost increase, because the consumers, they can't do anything. I mean, this is so beyond comprehension that they would just have to pay whatever is being charged, right? So with all this complexity, the supplier side have sort of just increasingly high power in terms of, frankly, for the lack of a better word, manipulating the market. So what do you do about that? Simplify it. Simplify, simplify, and simplify. So this is, I don't think we're going to go all the way there. I don't think the national market is going to go all the way there. But without going to a lot of weedy details, in the Affordable Care Act, the national law, there's some very key provisions that will push in the direction of making the insurance market simplified. So we would like to see that keep moving forward. Now, in terms of what does the Affordable Care Act mean to Massachusetts? Because we've already done a lot of that. Now there's a new law that we are required to comply with. Now, what does that mean to us? So much of the market may not appreciate, but this is actually a tremendous opportunity for Massachusetts as well, because there are key benefits that really apply to Massachusetts, and it's important that we all work together to seize the opportunity and maximize the new benefits that come to the state. A couple of things that I can mention. There is further expansion in subsidies. So the Massachusetts law set out certain rules to say who will have access to what type of subsidy. And then under the federal law, even if your income is a little bit above the Massachusetts threshold, you will still have subsidy. So that means health insurance could be more affordable to people who currently have trouble paying for health insurance. There is more help coming your way. So that's one. And then also, there are more complicated rules in terms of who can access the subsidy currently in Massachusetts. For example, a simple example is that if you work for an employer, that employer is offering you health insurance, but at the same time, the plan is not very good, or the plan is too expensive for your wage. Under the current Massachusetts law, a lot of them would not be able to access government subsidy automatically. So this is really what we call people who fall through the cracks. I was, one time doing a radio show, and there was a caller with that situation. It broke my heart, frankly, just hearing that story. And unfortunately, I was able to tell him that come 2014, your suffer will end. And that meant a lot to that person. So we have 97% of the people covered. There's still 150,000 of them out there. Many of them could be because they struggle to even access what is deemed to be affordable to them. Many of them, to Nancy's point, may not even know they are eligible for Medicaid. But we wanted to give ourselves and everyone who's willing to work with us a strong push to find those 150,000 people. So that's the first benefit of the Affordable Care Act, which is more generous, expanded subsidy. The second point is Nancy mentions that the federal law dramatically, at the national level, expands subsidized insurance from Medicaid to subsidized insurance through the exchange. And then the vast majority of that coverage is federally funded. And in Massachusetts, we already did that a number of years ago because we already realized that we need to make coverage affordable for these people. And then we paid for that with some federal sort of support, but we basically took the step in paying for that. Now, with the federal government finally coming in to take its responsibility, that does mean the Commonwealth has more freed up resources. And it's $200 million for half of 2014 alone. So this is significant resources that the state can use to address some of the long-abandoned other needs. So we are very sort of glad that we have this extra resources, especially when, as we all know, the market has been going through recession. There is a lot of public investment has been put on hold, and this is an opportunity for us to really do some good things with that new benefit, new resources. I wanted to say that there is one more thing in terms of the benefit is just that there is a lot of investment provided by the federal government to really build up infrastructure that will make access to health insurance easier for people. So for example, Medicaid I don't know how many of us, have friends or families having experience applying for Medicaid coverage. Typically, you have to go through tens of pages of paper application. And by the way, a few months later, you have to reapply. This is ending because we're building market leading, nothing, something that nobody has ever seen before, the new technology that will make access easier than you can ever imagine. You come to our website and you will be asked a few simple questions, and then you will be able to get through the eligibility determination process, and then you will just get to your coverage. And then this is a tremendous benefit to over 1 million people in the state in terms of their ability to interface with the system. Because we know a lot of people are struggling to get to their coverage for stupid reasons that they can't get through that system. So this investment costs money. I personally think it's visionary for the federal government to commit the resources to develop this infrastructure, because that really benefits the lives of countless people, and then it's a foundational component of making our healthcare market more efficient and more consumer friendly. These are the reasons why myself and my colleagues and many of the people that work closely with are excited about the Affordable Care Act, because this is not only extremely meaningful for the entire nation, but even for Massachusetts, the home of health reform. I would say, however, it doesn't mean that we can just glide past to 2014 without work. Nancy already alluded to that. There is actually a lot of work that we need to do to make sure that we go from the Massachusetts reform to the federal reform in a most efficient, successful way. The two laws are not exactly the same, so there is some policy work that my colleagues and myself and many others need to do to ensure that the rules are aligned in careful and responsible ways. People will not get confused, and certainly they should be very reasonable. And so that's policy development work. And a lot of that work is already complete. It's not 100% complete. And I would like to think that we have done a good job reconciling the two laws in responsible and thoughtful ways. There is a lot of infrastructure development, as I just mentioned. So we have IT experts working day and night to stand up the infrastructure so that that great technology-empowered service platform can be made available to the market. The last challenge, where I would just end my note on, is actually my personal, and I speak for many of the people who work work with me as well. My highest priority is to ensure that the people who already have coverage today, they will continue to have their coverage. Because to Nancy's point, this is going to be a bumpy ride. It will be rocky, and there will be glitches. And this is a very, very tough to understand market. It's a challenge to ensure that no one gets left out through the transition. No one wakes up one day of realizing the coverage gone just because you forgot to fill it or you did not fill out a piece of paper. It's very, very important for us to ensure that the 200, 300, 400,000 people that we work so hard to bring into the health coverage system are not pushed out unintendedly, but there is a big risk. So I would actually say that we need all the help that we can getting the word out. You will hear a lot from us in the paper, in the air, in the community. You will see the Health Connector. You will talk to people who are talking about the Health Connector and our sister agencies like Medicaid. People need to act. People need to look for information. People need to ask questions, and then ask yourself and your loved ones whether you are all set for 2014 in terms of health insurance, because this is extremely important to me personally, to a lot of the people who really care about this. Thank you.
I could start and end my remarks by saying ditto and ditto, but since Nancy's done this little tune-up that I'll say something pithy, I've actually been sort of worrying about that now. I'm here to endorse Nancy Turnbull for governor Jean Yang for Lieutenant Governor, and Michael Dukakis is Governor Emeritus. What do we say here, huh? And I'll just vote early and often. I actually did almost vote early and often yesterday. They gave me 2 ballots at the where I voted, and I said, no, 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 I know I live in Tip O'Neill territory, but I think you want one back. So I'm Mary Lou Sutters. It's a privilege to be with this incredible group who I admire greatly, and with all of you, and I'm looking forward to your questions. So you've now heard a little bit about the Affordable Care Act at sort of the national level, what we're doing in Massachusetts to ensure that Massachusetts always stays ahead of the curve when it comes to health care. And I'm going to drill down a little bit about one of the most forgotten, neglected parts of the healthcare system, and that is the issues of mental health and substance use disorders. And I do that, and I'm going to tell you a little story. I don't do this very often, but my interest in mental illness comes from having 3 generations of family members who have suffered and in one case had recovered from their mental illness, and that's my niece, I'm happy to say. But that was not true for my mother. My mother died 2 weeks after her 40th birthday from mental illness, from a severe mental illness, depression. Was not a sort of just, get yourself off the couch and, you'll be fine, which one doctor actually said to her, if she'd just get off the couch, she would be fine. This was a woman who for probably about 17 years suffered from very profound clinical depression. When I actually look at the photos of her, it's actually sort of painful. My mother was quite lovely, and yet when you look at the photos, she was always sort of a sadness on her face, removed from the rest of us, and I look at it and think, how is it we did not notice? Because in the 60s, people just didn't notice this. And somehow my mother was actually able to get up every day and work. But when she came home from work, she couldn't get up the stairs to get up to her bedroom. The couch became her bedroom. But the end of this story and how it connects to the Affordable Care Act is she became quite physically ill. Like some people with serious mental illness, my mother, after going to many, many doctors, turned to the bottle. And so alcohol became her drug of choice. It is what sort of calmed her in the evening. It's what helped her go to sleep at night. And I was complicit in that, and I would, in the morning, throw out the bottles. So she was hospitalized a number of times for what ended up being the treatment of cirrhosis. 6 months before she died, at the age of, I was 15, I became my mother's case manager. My mother was in and out of hospitals, and there I was. At one point, she was denied coverage because of a pre-existing condition. Well, we can check that one off due to the Affordable Care Act, thank goodness. And then later, she was discharged from a hospital because she no longer met medical necessity criteria. And there I was at the age of 15, flipping through her insurance, her health insurance, trying to understand what the definition of medical necessity criteria and utilization review criteria meant as a 15-year-old. I wasn't very successful, and when the hospital social worker said to me that my once vibrant mother should probably be moved to a nursing home to live out the rest of her days, I did what every angry 15-year-old did. I discharged my mother and took her home and took care of her. I can assure you that took care of any interest I ever had in nursing. But I will tell you this, it sure made me angry about insurance and thinking that there must be something else one can do to improve coverage for what was clearly a mental illness and substance abuse disorder. So that is why I have been, and that's also why I became a social worker, because I figured if that's what social work did, I could do a whole lot better than that too. So with that, you should know that my lens into healthcare in the Affordable Health Care Act is through the narrow lens of what we have not done to treat people with mental illness and substance abuse needs to get the services and treatment and supports they need, even though it affects a mere 1 in 4 adults in the United States of America. It is shame on us. I'm a worrier, so when we have our exchanges together, we can worry together. But I was thrilled with the Affordable Care Act. I will tell you that when I first, I actually have read the entire Affordable Care Act, not because I had insomnia, but because when I first opened it up on my computer and sort of did the search for mental health, behavioral health, and substance abuse disorders, it lights up as a Christmas tree for the very first time, I believe, in healthcare in America. So I was like, I can't believe this. Maybe I searched wrong. The Affordable Care Act, so just a couple of things. One is the Affordable Care Act is as close as we have come to declare that health care is a right in the United States of America. Isn't it about time that we joined the rest of the industrialized countries, right? It's just about time. And you've heard like the people who don't have coverage from Nancy and Jean. We have done a lot of things. I just want a little bit about regulation. We've done a lot of things right in Massachusetts around implementation of the Massachusetts healthcare law as well as the Affordable Care Act. I would suggest, however, we have not done a great job of regulating the mental health and substance abuse parts of insurance, and it's something that I continue to sort of be a little gnat about. The Affordable Care Act has gone a long way to ensure coverage, but it doesn't prevent illnesses. It just makes it easier to cover the costs associated with those illnesses, which is incredibly important when you remember that the number one reason why Americans file bankruptcy in the United States is not because you've lost your job. It's for medical reasons. And behavioral health, mental illness, and substance abuse are within the top 3 reasons why people file medical bankruptcy in the United States. The Affordable Care Act goes a long way to helping us fix that. 2014, as you've heard a little bit, will be a significant year in the implementation of the Affordable Care Act, and it has strong protections around mental health and substance abuse disorders. So I'm going to give you the Mary Lou top 10 reasons why the Affordable Care Act is, despite all of its messiness, when you have this kind of massive systems change, it is a good reason for us to be very supportive of this. So I'm going to give you the top 10 reasons, particularly around mental health and substance abuse disorders. I will tell you I had to stretch to get it to 10, but I've done that. 1, it's a clear acknowledgement that mental disorders and substance abuse disorders are real. It is a stigma buster, the Affordable Care Act. 2nd, and Nancy, I'm going to start patenting these things so I can make money off you. 2, the Affordable Care Act requires a basic benefit plan package for all individuals and small group markets that must include mental health and substance abuse disorders. No longer is substance abuse and mental health coverage optional. It has to be part of the essential benefits. I know we'd say, well, of course, but that has not been of course in the United States. 3, requires that all plans in health insurance adhere to federal parity law. About time. And I'll get a little bit more into what that means if you want. 4th is the expansion of Medicaid includes substance abuse and mental disorders at parity levels, which is incredibly important. Probably about 6 months ago, you might have heard my melodious voice on WBUR, where I said if I had a child with a mental health condition, I'd much prefer to have them on Medicaid than on a commercial insurance plan. For all the issues in Medicaid, it's actually been a far better benefit in the coverage of mental health disorders and substance abuse disorders in the Commonwealth of Massachusetts. So expansion of Medicaid, in my mind, is a really good thing, particularly for people who have mental health disorders and substance abuse disorders. I'm not using the term behavioral health. Substance abuse and mental health disorders workforce are included as a high priority. You heard Nancy mention a little bit about the investments in the Affordable Care Act. Well, there's clear acknowledgement that we have to address the behavioral health workforce issues. Number 7 is you can't be denied coverage for a pre-existing condition. People with mental health conditions and substance abuse conditions have often found themselves without coverage, in part because of the pre-existing condition requirement in the past. Substance abuse and mental health providers are eligible for community health grants. Again, you might say, well, that's not, that big a deal. But I can't tell you how many times we have had health grants available for where substance abuse and mental health providers have not been able to access those kinds of innovation grants that are out there. Number 8, substance abuse and mental health disorders are prioritized in the chronic disease prevention initiatives. The focus on preventive care and screenings. People with mental illnesses, like my mom, die often 25 years earlier than their non-disabled counterparts, not from their mental illnesses, but from untreated chronic health conditions, things that many of us will not die from, but people with mental illnesses and substance abuse disorders will. So for example, studies show that individuals with mental disorders are up to 70% more likely to smoke than those without. Part of the preventive care coverage will include things such as smoking cessation counseling, as well as the aids to help people to stop smoking. I don't smoke, so I can't relate to that one. Number 9 is the opportunity to integrate. Now listen carefully here, because there's a whole lot of talk about integrating physical and mental health care. For me, the opportunity is to integrate parts of our traditionally segregated healthcare systems through the provision of real care coordination. And number 10 is the expansion of the electronic medical records. And you're going to say, so how is that important? I'm sure many of you in this room know why that's important. How many times have you been at a doctor's office and you have to either recount your entire medical history, or someone has written down something incorrectly in your record, and you're sitting there saying, no. Actually, you know what? That just happened to me this past year, where I got a call from my health insurance wanting to know about I forget what they thought I had, Crohn's disease or something. I'm thinking, no, I don't think so. Are you talking to Mary Lou Sutters? And they had not yet brought together all of their records, and someone had written down a note that then became part of my record, and I get this call wanting to know why was I not getting treated for Crohn's disease, and I said, because I don't have it. But truly, with the right provisions, electronic medical records can actually help integrate services and supports for people with mental illnesses and substance abuse disorders. But let me tell you what my worry is. Despite all the things that are good in the Affordable Care Act, it takes a lot of effort to ensure that mental health conditions and substance abuse disorders are truly part of the same conversation as physical health disorders. We have passed 2 parity laws in the Commonwealth of Massachusetts. We have passed an autism insurance law in the Commonwealth of Massachusetts. And I'm really grateful that all of my friends in the commercial market say that they're in compliance with parity. And my response is, then how come the greatest number of complaints that go to the Office of Patient Protection, which is a grievance process around insurance, is behavioral health? So I just can't quite reconcile that. But I want to paraphrase MIT economist Jonathan Gruber. And as some of you may have read, I'm sure there's a few Boston Globe readers in the room, and you might have read Sunday's edit, was a large piece in the op-ed section. And one of the things Jonathan says, and he's an economist, not a social worker, is that despite the gains, there continues to be a widespread belief that mental health issues are not as serious or as worthy of attention as diseases like cancer and diabetes. We as a society, so I think he's talking about all of us, we as a society just don't care about mental health in the way we care about physical health. It's just not viewed as real health. So there's lots of chatter about integration of physical care and mental health, but not much else. And I think one of the great opportunities, however, that the Affordable Care Act gives us, however messy this tremendous piece of legislation is it gives us this one great opportunity where that window, that public policy window opens for us to truly talk about mental disorders, substance abuse disorders, in the same terms and conditions as we talk about the other medical conditions that affect us. As the governor has sometimes heard me say, it's about time we take the head and attach it to the rest of the body, and maybe we'll really treat us as a whole person. So with that, Gina and I sit on the Health Policy Commission in the Commonwealth of Massachusetts, and I'm sure at every commission meeting, Gene thinks that I'm like this little gnat. Every time we talk about some health issue, I'm like, behavioral health, mental health, remember, we need to continue to talk about this. But we do have this wonderful opportunity to finally rid ourselves of the stigma, and that is one of the true opportunities that the Affordable Care Act gives us. So with that, I think I will turn it over to our moderator for this wild Q&A.
Okay. Three of our best, and as you can see, they have been and are deeply involved in trying to make this law work here and nationally and in many other ways. Just a couple of comments, if I can. This situation we face where some states don't have to do it and other states are doing it, where did that come from? Any of you know? Because that's not what the law said. The law said everybody had to be part of this. What happened? Any of you know what happened? Supreme Court did what? Could be voluntary with the states. That's not what the law said. Supreme Court said that it was unconstitutional to compel states that didn't want to do it to follow the law. Based on what constitutional principle? Any of you know? No, that was another part of the opinion, which was equally lousy. Say again? Yes, but the federal government has hundreds of grant-in-aid programs, as we call them, in which the federal government says, we will give you money, Massachusetts, Nevada, Texas, Montana, but in exchange for that money, you have to meet certain criteria. If you don't want to do that, you don't get the money. And there were numerous situations when I was governor when Congress, in its wisdom, would expand Medicaid coverage. They added pregnant women, they added this, they added that, they added certain categories of very poor people, and it wasn't discretionary with the states. If you wanted to hang on to your Medicaid money, you had to comply. Governors, I remember one National Governors Association meeting in Cincinnati where people were mad as hell, not because the governors weren't for expanding care, but we had to come up with 50% of the cost, and we were going into another national recession, and our budgets were in terrible shape. So what was the constitutional principle? The court said it was coercion. Where does it say that in the Constitution? Where does it say that in the Constitution? It was coercing the states. Maybe it was, but that's not a constitutional principle, folks. I mean, this is a Supreme Court, if I may say, that's in my judgment, totally out of control. Totally out of control. So we have this really wacky situation in which some states, mostly with Democratic governors and Democratic legislatures, are moving ahead. A handful of states, Arizona, for example, with a very conservative Republican woman governor who's decided she wants to move ahead, and in fact has been pretty forceful about it lately. And then we have a state like Texas, which, as you just heard, has a higher percentage of uninsured people than any state in the country, which has just decided it's not going to do it and doesn't have to comply with the law as passed by the Congress of the United States. Think about it. You know, the result of the Supreme Court decision, which was decided the day after we had our forum last year, remember? The result, for those of us who support the law, was okay. The opinion was terrible. First, because of this coercion nonsense, and secondly, because they decided to repeal 80 years of jurisprudence and go back to the old Hughes Court, which FDR tried to pack. Remember? Because they kept turning down New Deal bill after New Deal bill after New Deal bill on constitutional grounds. One other point, and then we're going to have some fun. It's true, as Nancy has said, that a lot of the folks who are going to benefit from this bill tend to be poor and often members of minority communities. But don't kid yourself. 85% of the uninsured people in this country are working or members of working families. They're not loafing. They're not sitting around. They're not on public assistance. If you're on public assistance, you get Medicaid. These are working Americans and their families. Some of them working 2 or 3 jobs, no health insurance. And when they get so sick that they can't stand up, they end up in the emergency rooms and we're all paying through the nose. So don't think that this is some kind of welfare program. It's not. This is trying to make sure that all working Americans and their families have decent, affordable health care. And frankly, I don't think the administration or the Democrats in Congress have made this clear. They should, in my judgment, they should have been saying this from the outset. This is about working Americans and their families. Not all of whom are poor, by the way, who, as Nancy pointed out, suddenly wake up one day and they find out insurance is gone. Don't have it. That's what this is trying to do. And the final thing, just to underscore what Mary Lou said, is that for those of us who care very deeply about mental health and substance abuse, and often, as many of you know, they go together, as they did in the case of her mother. I mean, you know, you're depressed, you're down, and you self-medicate, often with alcohol. But we are on the verge, folks, for the first time in the history of the United States, of making it possible for people suffering from mental illness to get care when they need it. It's the first time in American history that that's happened, all because of the Affordable Care Act. So this really is a historic occasion, and we're on the threshold of something really important, but it's going to take a lot of work and a lot of effort. And you know, as I say to my students, it's great to pass the bill. Implementing the bill is hard. It takes a lot of work, and a lot of very good people are working their heads off to make this thing work. Okay, enough from me. Questions, comments, reactions? Yeah. And we have a microphone that we're going to pass around, and you guys can pass around that microphone in front of you, which I think is working.
Test.
Thank you for, is it working?
No.
Oh, okay. Thank you for a wonderful presentation. I am one of the people that is absolutely thrilled that this act has passed. Can't wait until it's implemented. While it was being put together, there was a segment of the bill, and I apologize, I can't remember all the correct titles, but, oh, is that better? Thanks. While it was being implemented, there was a segment of the bill that was talking about doctors having conversations with their patients regarding end-of-life care.
Right.
And
That was the death panel thing.
I was going to say, yes,
Right.
Barney Frank and others were being accused of
Right.
death panels. I think it's a wonderful idea. I'm not sure what happened to it.
What happened to it? It's taken out, but any primary physician who doesn't discuss these matters with his or her patient and their family, in my opinion, is derelict, because that's part of what a good family doc ought to do. So I'm not sure that it won't happen anyway. Is that on, Nancy? Pull it out. And okay. I'd try to fix it, but I got a charitable D in physics at Swarthmore College and went into politics instead, so I'm hopeless when it comes to this stuff.
Now it's working.
Yes?
Now it's working. Go ahead with yours, though.
Is this one working?
Yeah, but right up close to you.
It's a great question that you asked, because actually public opinion polls show more than 50% of Americans think that there are death panels in the law.
And of course, they aren't death panels at all. This is the kind of conversation that doctors and their patients' families in particular ought to have when somebody is close to the end of life. And, you know, pretty soon, folks, it'll be possible technically to keep people alive indefinitely on a machine. Serious. So these are not easy questions, and the notion that a doctor would not discuss these things with the patient and family is just, in my opinion, preposterous. Yeah, go ahead.
I have a question, I think, for all of you, but particularly Eugene, and that's, you covered a lot about the issue of the insured, but you didn't cover the issue about the provider. And the reality is that there's still large providers here in Massachusetts that do not accept the Massachusetts plan. Under the partner system, Mass General and the Brigham and Women's Hospital do not allow patients to come in if they have the Massachusetts plan. I know a friend of mine whose mother had ovarian cancer, and she wanted to have her mother treated in Mass General, and it was not accepted. And she actually went to Beth Israel Hospital, which did accept the plan, and she was able to get a consult at Dana-Farber, but she wasn't able to actually be treated there. So there's a huge disparity in terms of actually bringing more people into the insurance group, and then also not having providers that actually accept that insurance.
So this is a big question. It's a very good question, and it certainly is for all three of us, if not for a much bigger crowd, because this is
Keep that mic very close to your...
yes, very
your-
close,
that's
very
it.
very close. Thank you for that question. I wanted to say that this is certainly something I'm sure the three of us will all have plenty to speak about, and it's a bigger conversation as well. That is indeed a problem, but that problem almost goes all the way back to where we started from. Why is it, I mean, I'm not saying that's the only reason, but why is it that we have such a coverage problem? We had such a big insurance coverage problem. Why were so many people out of insurance? Because insurance was really expensive. And why is it so expensive? Because the medical care that people were receiving were very, very unaffordable, and it was increasingly so. And that was in part because some of the provider systems were getting increasingly high-priced, and that was in part because we didn't have an effective market, and then there wasn't consumer force. There wasn't much of a competition. Large provider system that had market power really didn't have any incentive or pressure to be more efficient. So that is a significant problem, and I'm not necessarily saying that by bringing coverage to every person, this problem is going to go away. One of the things that we have had to do in the past as a way of trying to rein in cost was indeed to say, insurance companies, if you have trouble maintaining your coverage policy sufficiently affordable, and because some of the higher price providers just do not come to agreement, then you can leave them out. And obviously, the outcome of that would be patients will have trouble accessing the providers that they need. I mean, that is indeed a trade-off that we had to deal with. It was a very, very painful trade-off. You probably have heard some of the buzzword, limited network, tiered network, this type of, depending on how you look at creative plan designs. But there is nothing creative about it other than the fact of trying to cut costs. So is that an ideal solution for our problem? No. What we are hoping is that this type of mechanism is finally going to put some pressure on the problem of our market, which is there are pockets of providers or other price drivers that are just too out of control. Now, what we are doing here at the connector and the market in general in terms of price competition is really just a small piece of it. Remember, there is no market, or the market is not really a market. We need regulation, and we need more, we need additional intervention to make the problem, to solve the problem. And that is one of the things, for example, Mary Lou and I are on the Health Policy Commission, and what we're trying to do is trying to really get to the delivery system itself in terms of thinking about what is driving the cost and what can we do, leveraging regulation or just transparency or anything else, all the resources that we could mobilize to really intervene and make the market more effective. I'm going to stop there, but my colleagues have...
When I was governor, this wasn't a problem because we regulated the price of hospital care. We had a state rate-setting commission. Nancy was very much involved. State rate-setting commission, which basically said, this is what you're going to get paid to the hospitals. It's like a public utilities commission, which says to the electric companies, this is what you're going to charge, no more. I left office, a guy named Weld came in, with a Democratic legislature, to be fair, and deregulation was in the air. We're going to deregulate everything. And we deregulated hospital costs. So we now have a situation, and in fact, the commission and its information arm is doing some very interesting work. And folks, you have no idea the disparity between, even among teaching hospitals, and what they're getting paid. And Partners is way up there. And the BI, New England Medical, and you know, these other places are getting much less with no difference in outcome. Now, why are we tolerating that? Beats the hell out of me, folks. I think it's absurd. Other countries look at this and they think we're nuts. You know, they have no idea why we're doing this. But if you don't regulate price, these are the kinds of things that are going to happen, and then you end up with these tiered networks and all this kind of stuff, and pretty soon people can't go to the general. Who's next? Yes, way over there. Thank you. Well, sorry. Yeah, you go ahead, Alan. You do the picking. Stanley.
I think what you folks are doing is terrific, but I've realized with my increasing maturity that I need supplemental coverage.
Keep that mic as close to your
I need supplemental coverage
Okay.
in addition to Medicare. And I wonder if there's anything in this new legislation that helps people like me who are struggling to have enough money to pay for the supplemental.
If you're poor, the answer is yes. But what about
I mean, if you're poor, the answer is yes.
if you're not so poor, can you get supplemental coverage?
And you're on Medicare. I'm sorry, couldn't.
Yeah.
So, I mean, a big thing that's going to make supplemental coverage much more affordable is the closing of the Medicare drug donut hole. I mean, the major cost in supplemental policies these days is prescription drugs. So as that, you know, the middle part, which Medicare doesn't pay, closes substantially over the next 8 years, that's going to make supplemental coverage more affordable.
What about hospital care? Isn't there, if you go into the hospital and you don't have supplemental coverage, can't they bill you?
Yeah, they can bill you. There's not, I mean, the Medicare donut hole closure is the major change in the Medicare program. I mean, there are a variety of things in the law which attempt to make quality of care and some parts of care for older people more affordable, so those should translate, you know, reducing readmissions that aren't necessary, reducing.
But Nancy, what about the bills we get from the hospital saying you owe X over and above Medicare? Say again?
What's the 20% co-insurance in Medicare? No, the bill doesn't substantially
Change that.
except on the Medicare side.
And there's
the
no
drug
way
side.
that somebody can get affordable supplemental coverage these days in the marketplace?
Well, we're not regulating that very much anymore.
I know
either,
that.
Governor Dukakis.
I know that. Answer, I guess, is that the Affordable Care Act doesn't do much for that.
Well, but I mean, part of your supplemental coverage or your Part D coverage is for drugs, and that's the part, the cost of which has been going up the most. So actually closing the donut hole will make a significant
Yeah,
dent
but
in that.
I've made at least a dozen phone calls to the general, who, as many of you know, Kitty has a monthly electroconvulsive therapy treatment, which has saved her life. And I keep getting these bills for $111. So I call them and I say, well, you see, we have supplemental coverage. I'm a state pensioner after all, right? So I have the GIC supplemental coverage. And, well, what is your ID number? Well, what's your group number? Oh, okay. Apologize. And I got another bill for another $111. You know, the amount of time that we're all spending on this foolishness, folks, is really unbelievable. You know, in other systems, health insurance is health insurance. It's not 82 different products and all this kind of stuff, and it's one of the reasons why our system is so expensive. Alan, yes.
Well, I just wanted to say in Massachusetts, you're fortunate because there is for seniors who are on Medicare, mass health buy-in programs. So there are, if you come to the senior center, make an appointment with a Shine volunteer, they'll be able to tell you it's based on income, but the income limits for a senior are generous, and they have different programs you are eligible for that will help you with some of those costs. Keep a little more money in your pocket and less being paid out.
Come over here, and there'll be somebody who you can work with, Stan, who may be able to help you get some additional supplemental coverage. Alan, who have you got? Remember the $64,000 question? I have a lady in the balcony, right? Any of you You're all too young to remember,
too young.
right?
So I have a
What was that? What they say?
question.
Lady in the Balcony Doctor, right? Remember that? He was on radio. It was pre-TV. Do I sound? It's been around for a while. Yeah. Go ahead.
I have a
Huh? Oh my God, the Beatles. This goes way back. This is okay.
So my question relates to a provider question also, but more related to mental health. You hear a lot about, people are insured, but they don't have access to a primary care physician. Is there a trend or a start to a trend with expanded coverage, which is new, with providers being more willing to be in a network or providing that? Having done that for my child, it was extremely difficult, and using my network of friends, I found somebody, and then it ended up not being in our very healthy insurance plan. So you think about people who don't have that access, and it's so great that the mental health coverage has expanded, but what's the connection with the provider?
How are we doing when it comes to family docs, psychiatrists, and others? How are we doing?
So, hello. That is the great question. So what insurance coverage does is help pays the bill. It does not, and this is one of the things I said early, is it does not guarantee access to care. However, we have seen some changes, and I think this is one of those sort of the changes happen slower than what you would like, which is in a number of primary care offices now, there are, particularly around pediatrics, there are now social workers, because we're cheap labor. There are social workers, social workers are embedded in primary care offices. And so, and BMC, Boston Medical Center, has a great program of having social workers available to primary care docs right there. So if there's a concern that is raised during a primary care visit around behavioral health or just something, a social worker immediately is available to the primary care doctor. And it's that transfer of the relationship from the primary care doctor to the social worker sort of helps around issues of behavioral health. Frankly, one of the biggest issues in behavioral health is the rates. And I hate to go to rates, but we've seen it repeatedly in Massachusetts around hospitals either wanting to eliminate their inpatient beds, psychiatric beds, or the like, and it all comes down to sort of really bad negotiated rates, because as we were up here, as the governor was speaking, we're sitting here saying there's no rate-setting commission in Massachusetts, so you have these incredible disparities of rates around the same service, regardless of the hospital where it's happening, and it's charged $1,000 here and $500 someplace else, which makes no sense. I think one of the big opportunities with primary care doctors is, because that is where the relationship exists. We're going to see a lot of people who are poor going to health centers, which is Massachusetts has a tremendous number of community health centers, and it will be a wonderful place for people to
By the way, the number under the Affordable Care Act of community health centers in the United States will double. Right now, about 20 million Americans get their health care from community health centers. We have 25 of them in Boston alone, 52 or something in the state. But they're everywhere, and by the way, have quite good bipartisan support. George Bush wanted a community health center in every county in the country, and those numbers are going to double, folks. So a lot of the folks, undocumented aliens and these kinds of folks who do not qualify for coverage, and a lot of people who do, increasingly going to be getting their health care from some very, very good places. Gene, let me ask you this. You're doing a lot, but do you play any role in trying to make sure that there are primary physicians out there for the folks that you're trying to serve, or is that beyond your assigned responsibility?
For the majority of the population that we serve today, this goes back to, you want
Right.
to figure out that sweet spot between regulation and competition.
Yeah.
We do require that the health plans that serve our population, each member will get a primary care physician within 14 days of their enrollment. That is extremely important. If a member does not have a PCP, we will know. We will know immediately. We will have to make sure that a PCP
They have
is
a primary care
identified.
provider.
If they cannot meet that requirement, we're going to put that member somewhere
Yeah.
else.
You know, this is slightly off the point, but I got to tell you this story. When one of you, I can't remember who, Mary Lou, I think, talked about New England about Boston Medical Center. The CEO of the Boston Medical Center is a woman named Katie Walsh, who's a native of Brookline. She's one of us. Her father was a police sergeant who was the spitting image of Ed King. I kid you not. He looked like a twin. But he was with me. So when King and I were running for the second time against each other in 1982, in the great rematch, Joe Walsh, when he was off, often would drive me around. And let me tell you something, folks. It was something when Dukakis and King would get out of the same car. You know, and people would say, Jesus, what's King doing with Dukakis? Dukakis, it's supposed to be Dukakis' event. It was Joe, Katie's father. She went to Yale, and she's now CEO of the Boston Medical Center. Anyway, one of our own. Who's next? Go ahead.
Once again, I'd like to focus on seniors.
On what, seniors?
On seniors.
Yes,
We're all
yes.
seniors. Is there anything in the Obamacare Act, any type of program that really helps our seniors to age in place instead of going to all these facilities that no one really wants to go to? Because we all really want to stay out there in our own homes as long as possible. So is there anything in this new package in the Obamacare that will help us age in place?
Nancy, what do you think?
Probably the most significant piece in the Affordable Care Act is around preventing, basically creating incentives for hospitals to not have multiple readmissions for individuals, and to be able to provide sort of care coordination and help people stay in their homes. There's some other initiatives within the Affordable Care Act that are to incentivize individuals to be at home, to stay at home and get the support you need. And after this, I can sort of go over some of those sections with you. So yes, there is and one of the ways they attack it is around anyone who's been discharged and is rapidly readmitted. You know, that's not great care for the individual, and it's expensive to the hospital. So there have been, you know, they're either incentives or disincentives, depending on how you want to look at it, but really helping hospitals create opportunities for particularly elders to be able to get the care you need at home and not have to be hospitalized and then readmitted.
Other systems tend to have folks who come to the home, care for people, do everything they can to help them remain in the community. What about the Affordable Care Act? Anything in there?
Not specific for elders.
Well, that's what I just said. So there was.
Well, there was a provision in the bill which was actually a going away present for Ted Kennedy, to tell you the truth, because it's called the Class Act. But in my view, it was not well drafted. It was voluntary, but not voluntary. Turned out to be quite expensive, and finally, it just didn't seem to work. The numbers didn't seem to work. I may have mentioned this before, but a wonderful guy named Bing Chen, who held the Frank Manning Chair in Gerontology. Remember Frank Manning at UMass Boston? And a good friend of mine had another idea, which I thought made great sense, and I could never get any traction out of it. He said, supposing those of us on Social Security put 1/3 of the annual cost of living increase in a long-term care trust fund. In other words, instead of getting the full cost of living increase, we'd agree, or we'd be required, that 1/3 of that would go into a long-term care trust fund. He said if we did that after 5 years, then there would be a rather generous benefit for at least a year, providing precisely for the kind of thing that you're talking about. Now, a lot of people said, yeah, but seniors want all that money, and they wouldn't. I had a student, a graduate student, who ran the Social Security office in Chelsea, which is the poorest town, poorest community in the state. And she was so interested in this thing, she decided to do her final paper on this. And she took a day off and just went to her office, went to the Social Security office in Chelsea and asked every single person who walked into the place, what do you think of this? And there were about 200 who arrived in the office that day. Now, this is Chelsea, very poor place. You'd think people would be very concerned about getting the full cost of living increase. She came back, she said to me, 197 out of 200 said they would support that. Now, notice the beauty of this thing. It's out of benefits we already get, simply transferring a portion of that benefit to long-term care. It would not force younger people to pay for this. It would be us Social Security people actually putting that money in this so-called long-term care trust fund. I think it's brilliant. I've never been able to get traction with anybody in Congress on this thing. I mean, and I think it would go a long way toward providing the kind of life for people in their older years that I think most of us would be supportive of. Paid for how? By a modest transfer of, future cost of living increases into long-term care. But just haven't been able to get anybody in Congress to pick it up and run with it. Yeah, go ahead.
Just a quick point of clarification. Ms. Yang, you mentioned a person who called you low income. I know an individual who works for a small employer and has a very poor health insurance policy with very high premiums, which actually serve as a deterrent for the person seeking care when and if she needs it, because that copay is such a deterrent. At what point should she and where should she go to find out about other insurance policies? You mentioned 2014, so I just want some clarification.
Well, we do talk to these people really all the time, because these are the people in need, and up till now, most of what we could do is just to say, well, unfortunately, we are not able to provide government subsidy because that's, just a glitch in the law. But come October 1st, we will have our the new connector door open. The open enrollment will start then. So the person should be able to purchase insurance for effective January 1st. But this is a complicated issue. So we actually have people standing by talking to consumers, understanding the specific situation, and trying to identify the best solution. So I would encourage your friend just to call us right now. Yeah.
Alan, who's next? Yeah.
Hi. I understand that here in the Commonwealth we're migrating from fee-for-service to a global payment system, and that sounds very good. As a layperson, I don't
Maybe.
Okay. But as a layperson...
This isn't the first time we've gone down that road, We used to call them HMOs in capitation. Now they're ACOs and global payments. I mean, what's in a name?
But as a layperson, I don't understand why I wish we were migrating away from employers supplying insurance to everyone getting their insurance through one of the programs in the connector, because as an employee and as a business person, it makes you stay with jobs you really don't want to stay with for the insurance. And I'm a Democrat, and I'm pretty left-wing, but I think it's true that the smallest companies, 50, that have to provide health insurance to their employees, they're under a double whammy. They have the highest rates, I believe, and they have to amortize those rates under the smallest company footprint, if you will. So, but nobody has mentioned transitioning away from the transition I'm talking about. Could you comment on that briefly?
Well, look, lots and lots of countries with universal coverage have an employer-based system. Lots of them. Germany does, Japan does, works pretty well. And when you think about it, aren't Social Security and Medicare employer-based? Now, admittedly, they're universal, they're tax financed, but employers have to make a significant contribution. So I'm not sure there's any magic in moving away from an employer-based system. The question is it going to be regulated in a way that provides good care at affordable prices? And if traditionally or historically a country is kind of, I mean, where did the German and the French and the Japanese systems come from? From a guy named Bismarck, who was a conservative. He was worried about all these Marxists running around, talking about violent revolution, right? So Bismarck, the 19th century in Germany, said, hey, we better do something before these folks, blow us out of the water. And Germany came up with this very broad-based, employer-based system, which includes not only health care, but retirement and disability insurance and all this kind of stuff, shared employer-employee. And Japan, in those days, as it was coming out of its shell, kind of looked around and said, well, that looks good to us, so they have the same system. Korea's got an employer-based system, and so on. So it's, the real question, and everybody up here has mentioned, is are you going to regulate the system in a way that ensures it's affordable, eliminates as much of this administrative Mickey Mouse as you possibly can, which is costing us billions, and fairly covers everybody. And, if you were to say to me, Dukakis, in your heart of hearts, what were you before? I'm for universal Medicare. But if you've got a country that kind of historically has done it through employers, there's nothing wrong with that. But it's got to be regulated. And, you've got to, and who was the president who proposed such a plan, by the way? Richard Milhous Nixon. And if Ted Kennedy were here tonight, he would tell you that the worst political mistake he made in his entire career was not in joining with Nixon right away in 1971 behind the Nixon plan. Had he and Labor and the Liberals done so, folks, we'd have had a pretty darn good system since 1971. But by the time Kennedy got around to deciding maybe we ought to sit down with Nixon and stuff, Watergate hit. That was the end of Nixon. That was the end of the Nixon plan. And he'd be telling you tonight that it was a lost opportunity and that he regretted it. Alan.
I wanted to ask a question. A couple of years ago, we had a speaker in the panel who was the architect of the Vermont connector or the Vermont plan, and the suggestion there was that this might be an entree to a single payer, or that was what was suggested. And I wonder if that's still on the table, if there's any progress in Vermont. What are they doing up there?
Nancy, what's happening up there?
Oh, I actually think Vermont's the most exciting state that's doing really innovative things at the moment. So their single-payer type approach is going full steam ahead. And I think they're going to make great progress. They're regulating much more up there than any other state. They're a small state. They have only a couple of health insurers, but they're going very much forward, and I think that's a state where if they can be successful, cutting down administrative costs, reducing the number of options people have, giving everyone good options, but we're going to learn a lot there, and that could be a model for other states. So it's a great question, Alan. Well worth keeping your eyes on what's going on.
But it doesn't kick in until 2017 now.
That's right.
So we shall see,
We shall see, but...
But they're certainly doing some, and I think they already have community rating anyway, don't they?
They already had community. I mean, they're very different.
You all know what community rating is? Everybody pays the same. There's none of this, you pay this, and somebody else pays this, and somebody else pays this. Rates are uniform across the board.
And they're also doing phenomenal things about trying to integrate care, very interesting things on long-term care, a lot of interesting work there to try to keep people in the home and out of nursing homes, so we can learn a lot from what Vermont's doing.
Okay.
My question is about dental care. At what point will the whole system recognize that teeth are part of the human body and part of our health?
First, Mary Lou says we've got to connect the head to the rest of the body, and as part of the head, maybe we can connect our mouths and our teeth, right?
There's a lot of similarities. I refer to them as the entals, dental and mental, right? If you think about it, right, insurance coverage, right, carved out, small benefit, optional for plans and the like. The Affordable Care Act actually, what are you going to say? Oh, sorry. Go. The dental is actually referenced. I was going to talk a little bit about oral health. Oral health is actually referenced in the Affordable Care Act. It's part of the Medicaid expansion programs. Again, it is the states that are not expanding their Medicaid programs will not. And there's
What about pediatric dental care? Wasn't that supposed to be part of the essential services?
Yeah,
Yes?
pediatrics is.
It's
but
in.
Yes, but not adult.
Yeah.
Adult is optional for states.
Sorry, all us old guys, no luck. Gene.
So it's not a solve for all the problems. Dental, we're really at an infant stage in terms of addressing this big problem. But there are some good things about it. So to Mary Lou's point and the governor's point, there is a provision in the Affordable Care Act that, as part of the, and Mary Lou mentioned, what's something called the essential health benefit, which certainly includes mental health, for example. The health plans that are sold in the market, in the individual market of these, must have these essential benefits. And then pediatric dental for children up to age 19, actually, is included. What that means is that insurance company, in order to sell a policy, pediatric dental benefit needs to be included. So that does mean that children, at least, our next generation, hopefully, is going to enter a different age. One of the things that is a little bit more immediate for adults is that I don't know how many of you have tried to buy a dental coverage on your own in the market, and if you have, probably it was pretty difficult. And it's not only hard to find, it's really expensive. The reason it's really expensive is because when an insurance company gets a call, someone wants dental coverage, the company may say, this person probably has very bad teeth. So I'm going to have to make sure I get my money back. So this is the dynamic where, insurance just doesn't work, because the only people who will, go through the trouble finding the policy is probably those who need a lot of service, and on the other end, adverse selection. Exactly. I'm just trying not to use the words that don't make a lot of sense. So what we are trying to do is to break down that barrier, so to make access to dental coverage a lot easier, so that people who may have pretty good oral health, but they just wanted to have, a way of accessing good care, will actually be interested in buying dental insurance as well, so that market is going to be much more accessible, more importantly, more affordable to people. Again, that's a concept, it's a vision. It needs to play itself out. So come 2014, if you come to the connector, we will have dental plans as well. And then the good news is we actually, look for, sort of solicitate coverage policies from insurance companies. We got a lot of responses. So there will be 5
Good responses.
Good responses.
That's great.
We'll have to see, exactly how much they're going to charge, but they are going to be competing on our product shelf. And come look and then see if you can find a coverage that is good for you.
All right, I think we got time for one more question. So, yes, ma'am.
Hi, I'm going to address, there is a
Got to put your mic right up close to your
there's
mouth.
a concern in a multicultural community, and a large number of elders and people with disabilities lost their coverage because of language barrier and literacy issue. Is there any provision to do outreach in that population, especially with the health connection coming?
How about that?
So I would say that yes, but there is a lot more work to be done. I don't think that I don't think you can ever do a good enough job to ensure that people in different ethnic groups and different language needs have the equal access as English speakers. There's a lot of work to be done. But that being said, for example, there is a requirement for communication by, for example, the health connector and all the exchanges will have multiple languages. Our outreach workers, our customer service centers will all have multiple language capabilities. That is a requirement for the people that we hire and the contractors that we use. So come to us, you will find the person that can speak your language. Yes, navigator is, when I said outreach workers, they're actually a particular type of person. You will probably hear the word navigators. They're called navigators by the law. Their job is to help you navigate through the system and get to your coverage. we require these people will have multiple language capabilities.
Señores y señoras, desgraciadamente, la noche está terminado. Muchas gracias. Pues, we've got to wrap this up, but Alan, to you and to all of our friends who are friends, thank you again for a great discussion. We're on the verge of something very historic, folks. And these three terrific women, along with lots of other people, are working their heads off to make it work. And we're way ahead of the rest of the country, as all of you know. But the fact that we are, while a point of pride for us, reminds us that there are going to be millions and millions and millions of Americans who will not be permitted to take advantage of this law, thanks to what I think was an absolutely dumb and outrageous decision on the part of 5 men on the Supreme Court of the United States. So, five well-insured men whose health insurance is being paid for by you and me. Thank you all very much, Alan. Thank you.